Diagnosing psychological disorders is a tricky topic indeed, but before we dive into the issues surrounding diagnosis, it's important to first consider a more basic question. How can we distinguish different behavior from disordered behavior? Let's consider some historical examples of extreme behavior. Take post-impressionistic Dutch painter Vincent van Gogh. He's one of the best known and most prolific artists of his time. He created over 2,000 works of art in a career that lasted only 10 years. This painting, entitled Self-Portrait of a Bandaged Ear, is a glimpse into his unusual behavior. Van Gogh did this painting after having an argument with a friend, and in a fit of rage he took a razor and cut off the lower portion of his left ear. He then wrapped the earlobe in a newspaper and gave it to a prostitute named Rachel, telling her to keep this object carefully. So, for a bunch of reasons, Van Gogh was certainly different than most other people. On the one hand, he produced some of the most influential works of art, but in his personal life he was prone to extreme and unstable behavior. The painting above is one demonstration of his self-harming behavior, and he eventually committed suicide. There's much speculation about the cause of Van Gogh's unusual behavior. He had several major depressive episodes as well as manic and psychotic episodes, so most people agree that he likely suffered from some sort of mental illness. But let's consider another case. Witold Pilecki was a Polish soldier and founder of the Polish resistance movement in German-occupied Poland during World War II. He was voluntarily imprisoned in Auschwitz in order to secretly report on what was happening there. He stayed for 2.5 years and then later escaped. This behavior is certainly different than what most people would do. This mugshot here, however, is not from his time in Auschwitz, but when he returned back to Poland and was accused of treason. He was imprisoned, tortured, and executed, not by the Nazis, but by the Soviet-backed Polish government. This photo was taken at his trial, and although he doesn't look happy, he also doesn't look disheartened. Like Van Gogh, Pilecki's behavior intentionally caused him harm, no doubt about it. But the circumstances and motivation for his actions means that history remembers him as a hero, not as disordered. These two examples highlight the challenge in distinguishing different, in the case of Pilecki, from disordered in the case of Van Gogh. The current theory and practice of diagnosing mental illness has been heavily influenced by the medical model, which states that mental illness is best diagnosed and treated as a medical illness. This perspective on mental illness contrasts earlier views that considered mental illness to be caused by moral weakness or even demon possession, and treatments often involved extreme measures like drilling holes in the skull to release evil spirits. The medical model is certainly a move in the right direction based on the evidence we have about the biological basis of psychological disorders, but the medical model presents some of its own challenges. Let's take an example of a clear physical medical problem. A wound like a deep cut to the finger. The physician can tell, without even talking to the patient, what's wrong and how to treat it. Clean the wound to prevent infection, stitch it up, and bandage it. Easy peasy. But some physical conditions aren't so obvious just by looking at someone. Take a heart arrhythmia or a regular heartbeat. You can't tell just by looking at someone whether they have a heart arrhythmia. A doctor can talk to a patient and get some idea about symptoms, but it's not as obvious what's wrong, like with a finger wound. Using a simple device, like a stethoscope, or an ear to the chest in a pinch, lets the physician know very easily what's going on. What about somebody suffering from depression? Certainly you can tell by looking at this man that there's something wrong. But maybe his hockey team just lost the final. Maybe he'll get over it. Maybe he's been feeling this way every day for months. Clearly it's necessary to talk to the person for some time to differentiate different from disordered, so diagnosing psychological disorders involves a bit of a judgment call. We can't tell just by looking at someone what's wrong, and we don't have any devices to tell us definitively what's going on. So what information do diagnosticians like psychiatrists and psychologists use to make their decisions? The general rule is that something is considered a mental disorder if it meets these 4 Ds. First of all, it's a disturbance in thought, emotion, and behavior. It's deviant or different from normal. It's distressing. In other words, it causes discomfort, suffering, or anguish. And it's dysfunctional or interferes with everyday functioning. It's only when all 4 of these conditions are met that a condition should be considered disordered. One of the first attempts to provide some guidelines about diagnosis was German psychiatrist Emil Kraepelin. In his publication, Compendium der Psychiatrie in 1883, he put disorders into categories so that diagnosis could be standardized and measured. It wasn't until 1952 that a similar attempt was made in North America by the American Psychiatric Association, or APA, with the Diagnostic and Statistical Manual of Mental Disorders, or DSM for short. The DSM has become the standard in North America for psychiatrists, psychologists, medical insurance companies, and others involved with diagnosis. Let's look at the history. The DSM can be and should be considered a work in progress. The 1952 edition was the first North American classification and was about 130 pages in length. The DSM-2 was published in 1968 with some modifications to the original and not a lot added to the length of the document. The DSM-3 came out in 1980 with a revision, the DSM-3R, in 1987. This was revamped to make the guidelines consistent with other tools, like the International Classification of Diseases, or ICD, used by the WHO. This update greatly increased the size of the document to almost 500 pages. The DSM-4 came out in 1994, followed by its revision, the DSM-4TR, for text revision, in 2000. This attempted to provide clearer diagnostic criteria and emphasized an empirical, evidence-based approach. This greatly increased the length to 886 pages. Most recently, the DSM-5, which ditched the Roman numerals, came out in 2013, and there were some changes to how disordered behavior is viewed. In previous versions, there were separate axes to consider, but this was replaced by a dimensional approach that places behaviors, thoughts, and emotions along a continuum. The most recent revamp also increased the length, so the current version is 947 pages in length. Although the DSM is a useful tool for treatment providers, it is certainly not without criticism. One criticism of the DSM is that it medicalizes normal behavior. Now, the DSM uses a dimensional approach in placing disordered thought, emotion, and behavior along a dimension or a continuum, so it could be considered as normal or extreme versions of behavior rather than a black and white designation. Another criticism is that the DSM is based upon the North American and in particular the APA perspective. There are other ways of classifying disorders, for instance the International Classification of Diseases, the ICD-10, used by the World Health Organization and is used in Europe and India over the DSM. Another big criticism is that there are too many categories based upon shared symptoms and not biological underpinnings, which may be more useful in considering treatment. Another huge problem in the diagnosis of mental illness is the stigma surrounding it. Diagnosis can lead to stigmatization because as a society we have a tendency to judge people with psychological problems, and this can lead to negative stereotypes. This is an enormous barrier since it means that people often don't want to admit they're suffering from mental illness and might be hesitant to seek professional help. It also means that people might not get social support they need from their friends and family, which is really important in overcoming psychological disorders. A number of initiatives, like Bell's Let's Talk Mental Illness, have tried to raise awareness about mental illness and reduce stigma, and has been championed by Canadian Olympian Clara Hughes, shown here as the flag bearer for the 2010 Vancouver Olympics. She won 6 medals in both cycling and speed skating, but suffered from bouts of depression throughout her life. By talking openly about her own struggles and how sports helped her overcome them, she's trying to change the way that society views mental illness. So this summarizes both the history of diagnosing psychological disorders and some of the challenges faced in trying to make an accurate diagnosis.